Good evening. Thank you for joining us tonight. I am your host. My name is Patrice Delafontaine, and I'm Executive Dean at the Tulane University Health Sciences Center. And we're delighted to offer tonight's program focusing on COVID-19 and healthcare professionals recognizing and responding to stress in adults and children. With us tonight are Dr. Hinshaw-Fuselier and Dr. Khunkhun from the School of Medicine, along with Dr. Charles Figley from the School of Social Work. Their work is amazing and very much recognized, and we're delighted to bring them to you this evening. Sarah Hinshaw-Fuselier is an assistant professor of psychiatry and behavioral sciences at Tulane University School of Medicine and is the clinical director of the Tulane Early Childhood Collaborative, a program providing mental health consultation to pediatric primary care clinicians. She focuses on clinical work with young children and their families and improving infant and early childhood mental health care through program development, consultation and training, and policy and advocacy efforts. Dr. Khunkhun has completed triple board training in psychiatry, child psychiatry, and pediatrics at Tulane University School of Medicine. He's interested in ways to improve retention through improved doctor-patient relationships, as well as optimizing patient care. He has focused as well on providing and promoting mental health care in different environments. In his current position as medical director of the Center for Resilience, he works with Orleans School District in providing mental health treatment to children and adolescents with emotional and behavioral disabilities. Dr. Charles Figley is the Tulane University Paul Henry Kurzweg Distinguished Chair in Disaster Mental Health and Associate Dean for Research, School of Social Work professor and director of the award-winning Traumatology Institute. Since his arrival at Tulane, he has served as co-founder of two graduate programs, namely founding program director of the Master of Science degree in Disaster Resilience Leadership Program and founding program director of the City, Culture, and Community PhD program. At this time, I will turn the program over to Dr. Hinshaw-Fuselier.
Thank you. I think maybe we're just waiting on slides. Great. If you could advance that slide, I'd like to just begin this evening by taking a moment to acknowledge all of the stressors that everybody is experiencing. I think that they're unavoidable at this point, and we all know them. They're everywhere. They're in the news, they're in our personal lives, they're in our professional lives. But some of the things that I think we're recognizing are a lot of anxiety about illness and about health. There's been widespread economic impact from this pandemic, a lot of loss and grief related to all the deaths, social isolation in a way that we have not experienced it before, changes in childcare and educational environments and trying to adjust to virtual learning and having children home and trying to work. And I think this pandemic has really led us to an unrecognizable fact of the inequities that have existed in our society. And that's resulting in a lot of conversation, a lot of anger, a lot of exhaustion, and hopefully a lot of opportunity. I'd like to also acknowledge that there are different risks for different groups of people through this pandemic. And we've seen a disproportionate health and economic impact on African Americans. We've heard reports of increased hostility and aggression toward Asian Americans. We've heard many stories about immigrants being afraid to seek treatment or being ineligible for benefits that are available to others. And of course, the anxiety related to exposure for essential workers, including healthcare workers like yourselves. And a lot of folks are meeting at the intersection of these groups, which really compounds the stressors. So the other speakers this evening are going to focus on more adults and healthcare, but I'd like to begin this evening by having us think more about children and families. If you could advance the slide, please. Thank you. So we're really at the beginning of trying to understand what this particular pandemic means long-term for families and for children. But we do have some initial studies and reports, and we can base a lot of what we know on previous disasters that have occurred. So for example, we know with quarantine that we see increased levels of adult anger, confusion, post-traumatic symptoms, increased substance abuse, and increased domestic violence. And from previous disasters, we know that there are increased mental health problems in the aftermath. And this is true even for young children. So we tend to overlook young children, often thinking that they're too young, they won't remember, it doesn't affect them. But even young children can develop these mental health problems like post-traumatic stress disorder, anxiety and mood disorders. You can see disruptions in their behavior and their sleep, and in fact, biological changes. Next slide, please. And so young children are actually especially vulnerable to the impacts on their caregivers and on the adults in their lives because they are so uniquely dependent on their caregivers. They really require sensitive and nurturing caregiving in a safe and stable environment to be able to develop in a healthy way. So young children really can't do their own regulation. They depend on co-regulation with the adults in their lives to help them learn to manage feelings and to learn to manage behaviors. And so when those adults are experiencing increased stress, it really makes it difficult for the children because the adults in their lives are less available emotionally to help support them. And this can lead to anxiety for kids and can lead to a negative impact even on the developing brain and the brain architecture. And we know from research over the last couple of decades that there are current and long-term effects on both physical and mental health when children are exposed to this kind of stress. Next slide, please. So let's just take a moment to identify what we might be seeing and how we can notice reactions to stress in children. And we'll break it down a little bit by age, but generally speaking, you're going to see a lot of the same things across age ranges, but it'll manifest differently depending on the ages. So your littler kids may have increased irritability, more temper tantrums, maybe new fears and anxieties. You might see regression in previously acquired skills like speech, body regulation, maybe some increased clinginess. And then jumping up to that school age, you may see irritability, whining, aggressiveness, nightmares, again, those kind of body disturbances, sleep, appetite, maybe physical symptoms like headaches, and they may even begin to lose interest in being with friends or doing things that used to be enjoyable. And similarly for adolescents, you may see more of those physical symptoms, those disturbances in body regulation, maybe agitation or apathy, isolation from peers, and maybe more concerns about stigma and social injustices and things like that. Next slide. So I don't want to spend a lot of time on how we should respond. There are a lot of resources available for adults to learn and to know how to respond to children's stress, but a couple of things that are true across age ranges. We're really looking for adults to be patient and tolerant with children, to provide comfort for those younger children, reassurance for older children, to encourage expression of feelings and concerns through play with the younger children, through conversation with older children, really doing some health promotion and maintaining routines in the family and in the home can be really helpful to kids. And also media exposure. Little kids don't need to see what's happening in the news, and older kids need limits on media and that exposure, and then they need opportunities to talk about what they're seeing and what they're hearing. Next slide, please. So I want to return to talking about stress and thinking about cumulative stress. We began by kind of thinking about all of the things related to COVID, but there's a lot else going on. So we have those kind of cumulative stressors related to the pandemic, illness, loss. We have many folks now who are facing food insecurities, housing insecurities, and as I mentioned earlier, this kind of racial reckoning and the social unrest that has come about during this pandemic. We've also got natural disasters occurring. We've got fires out west, we've got hurricanes in the south and threats of storms. And then we have communities and people who are coming to all of this with a history of trauma. So we want to recognize that the more adverse experiences people have, the more likely they are to have negative physical and mental health outcomes. And I have a quote here that's from the Harvard Center on the Developing Child from a recent paper that they've published online, just to call attention again to this need for us to really look at the early life origins of susceptibility to adult disease. Next slide. So what are we to do? Clearly there are social level things that need to be done, programmatic level things that need to be done, but what can we do as healthcare providers? So intervening early matters. We know that it makes a difference to catch things early. We have treatments that work. We unfortunately have a real shortage of mental health providers. So pediatric healthcare providers become even more critical. And in this time of pandemic, when children haven't been in school, they haven't been around a lot of the caring adults in their lives who may notice when things are going wrong, who may notice when the violence at home has increased, for example, they're not getting spotted potentially by those caregivers. And so when they're making it to pediatric visits, we really want to make the most of that and identify when things are not going well and help those families. There are some barriers to this. One of the things that we know from our work in mental health consultation is that the comfort level and confidence about dealing with children's mental health issues is pretty low in pediatric primary care. And then on top of that, we have the added stress of COVID. So healthcare clinicians themselves are experiencing personal and professional stress. And it's really hard to be at our best when we are experiencing those things. So one of the solutions that we have is mental health consultation for pediatric healthcare providers. And I'd like to just spend a few minutes telling you about one of the programs we have here at Tulane that is working in this capacity. If you could advance the slide, please. Thanks. So the Tulane Early Childhood Collaborative was started in 2013 by Dr. Mary Margaret Gleason. We are an interdisciplinary team of child psychiatrists, psychologists, clinical social workers in the Institute of Infant and Early Childhood Mental Health. And we provide mental health consultation to pediatric primary care clinicians in the New Orleans, and very soon we're excited to expand to the Baton Rouge area. So our goal is to build pediatric healthcare professionals' capacity to identify risk factors early, to promote family well-being, and to respond to mental health issues in children birth to 6 years old. Next slide. So we have kind of three main ways of providing this support. Primarily is the clinical consultation. So we have our mental health clinicians are available to meet with pediatric healthcare providers by phone and video and some on site. And we can talk about general questions, and we can also talk about patient-specific clinical questions. We provide resource and referral information, and we may actually meet with the family as well. We also can provide trainings for pediatric practices around children's mental health issues. And then we have a website that has a lot of resources and information for families and for providers. So let me just take a moment, thank you, to advance. And I'll walk you through what that actually looks like. So recently, we were in touch with a pediatrician who had a patient, Tommy, age 4.5, in her office. Tommy had a history of being kind of disruptive, non-cooperative. He was the kind of visit that's a little bit difficult to manage in the clinic, running out of the exam room, hitting people. The pediatrician knew that he had a history of being sent home from preschool for disruptive behavior. Since COVID, Tommy's aunt, who was his caregiver, had really experienced a lot of increased stress. She was able to work from home, but she was trying to manage him being in virtual school. She's hearing from the school about provocative behaviors. She reported he had difficulty concentrating. And so the pediatrician was considering medicating Tommy for attention deficit hyperactivity disorder. And the strengths that I'd like to point out here in this case are that the pediatrician and the caregiver both recognize that this is not typically developing behavior and that there was a problem. The caregiver was able to ask for help, and next slide, the pediatrician also was able to ask for help, which was great. If you could go to the next slide, please. So our consultant was able to do a screening to look at trauma, environmental risk, behavioral concerns, parenting stress, was able to do an observation of Tommy and his aunt together and review symptoms. And it turns out that Tommy had a lot of trauma, pre-COVID trauma. His biological mother was mentally ill. She was substance addicted, and he was home when she overdosed. His father was incarcerated, and he was home when his father was arrested. During those first 3 years of his life, when he was living with the two of them, he was neglected and was often found out in the street, needing a diaper change and that kind of thing. So the consultant recognized PTSD in Tommy, and resultingly was able to provide resources for the aunt to give some psychoeducation about trauma, to give some parenting resources, and to facilitate a referral for trauma-focused cognitive behavioral therapy, which is a therapy we know to be effective with preschoolers who have experienced trauma. For the pediatrician, our consultant was able to provide some information about follow-up care and to give some guidance as to when to think about, examining him for ADHD again, to see after treatment if that was still a concern. Next slide. So the benefits here is that the consultation really allowed for an identification of the trauma history, and that may not have occurred in the absence of consultation. And it allowed for a more precise intervention for these symptoms that Tommy was experiencing. We were able to see reduced family stress in that the caregiver was able to talk about what was happening and to learn some strategies for managing some of those challenging behaviors. And it was an opportunity to help reduce pediatrician stress. So in this case, the pediatrician was able to be more confident about the diagnosis and the treatment plan for Tommy, and to feel professionally supported at a time when, the pediatrician herself is feeling a lot of stress professionally as well. Next slide, please. So I just wanna also call your attention to some other consultation programs that we have here at Tulane. The Louisiana Mental Health Perinatal Partnership is modeled in the same kind of way as the Tulane Early Childhood Collaborative, but this is geared toward obstetric providers and perinatal health providers, and that's available statewide. And then TICES is our kind of our leader in mental health consultation. They've been for a long time providing statewide consultation to childcare. And the last thing to leave you with is a slide of resources. The next slide has some resources. All of these organizations have COVID-specific sections, and many have statements and resources on inequity. So I think we're ready to turn it over to the next speaker.
So I think we're going to have Dr. Khunkhun follow. We can have his slides up.
Thank you. Good evening, everyone. So today what I'm going to try and do is talk a little bit about how stress can play out in the front lines. And this, it could probably pertain to things that happened even pre-COVID in healthcare environments that are strapped, but also probably got worse as COVID came through. And I know I put down what stress can look like on the front lines. I personally was not in hospitals, but I can tell you that I lived with somebody that was. My wife was a palliative care physician at LCMC, and she did a lot of work with touching base with families and being there with families when their loved ones were dying. Next slide, please. So I wanted to start off with, I know that, that we had mentioned this earlier, but as everyone knows, COVID, it's just really clear that people were dealing with something that is unpredictable, overwhelming, and that has led to a significant amount of deaths. Either if you're in a hospital, clinic, or even at home, we've had to blend our professional and personal lives, and probably are feeling that we are not providing the best care that we can for our patients, or taking care of our loved ones the best ways that we would want to either. That blend has been very challenging for a lot of us, whether you're in hospitals or in clinics. Next slide, please. So what I want to do is talk a little bit about what kind of thoughts that we could be having through this time, and sometimes how harmful these thoughts can be. And one of the things that some people can go through while they're in these types of environments that I have to be there more for my patients that are suffering and dying. If there's a bad outcome for this case, then I'm not really doing my job as a healthcare provider. My job is to get them better, to feel better. I mean, in order for, and then another thought could be, in order for my patients to do well, I just need to do more. I need to spend more time researching things at nighttime. I need to be up more. I need to be in the hospital more. And I think a lot of us have felt this during this time. We just feel a need to be there for our patients. On the other side, we feel a need to be there for our families as well. Next slide, please. So, you know, when you think about this, you know, my job at Center for Resilience is that I work with a lot of kids that have been involved in juvenile justice and that have engaged in really high-risk behaviors. I can tell you over the last 4 years, and really 3 during COVID, have gone to juvenile detention for serious violent crimes. And for all of these cases, I've had to think about what can I have done differently to kind of help them get to a good place. And so those are a lot of things that we think about when there are bad outcomes. So some of the thoughts that kind of run through our mind is that when we're exposed to an overwhelming amount of suffering and dying, our sense of competence as healthcare providers is really tied up into patient outcomes. So for these kids that ended up going into jail, I could think about me not being a good enough physician to make sure that they didn't get to that place. And for people that were working with people in COVID or patients with COVID, if the patient had died, then there was something that I had done wrong. And so a lot of our sense of competence is tied up into what happens with patients. So this at times really makes us feel pretty hopeless. We feel like we need to spend more time for the next patient that comes around. And sometimes we'll even use practices that may not be indicated, but we just got to do something. And then sometimes we even push others to do things as well too. And sometimes we may not even include other people in the plan that we're developing, and that we're the only ones that can do it. So instead of involving everybody else or coming together as a team to figure out how to address this really serious, stressful problem, that we just feel like we just need to do everything that we can do. This thought process very well may not lead to change in patient outcomes, but it can certainly lead to burnout in healthcare professionals. Next slide, please. So how do we kind of address these things with ourselves and with staff? So first we do need to recognize what is going on and what are we truly dealing with and how hard things are going to be. We need to be really very realistic about what can we do for these cases and openly discuss those feelings and thoughts surrounding what can and cannot be done. It's an idea of really thinking a little bit about what are realistic things that are going on with these cases and what can we do to best help them. So then we have to come up with a plan within our own scope of practice that can best manage the situation. So, you know, during COVID, all of the kids in our program were home, and I was so worried about all these kids and thinking a little bit about what can we do, because like they're not coming to school anymore, and then coming to our program, you know, we have to, like, we were protective for them. They're not being out in the communities. So, you know, we had to readdress what can we actually do. And I think that what we really moved towards was that making phone calls to families just to check in. We can't really expect them to do really good individual therapy work or anything like that. We can't expect them to do the great in academics when we first went into quarantine, but we could ask about how are they sleeping? How are they eating? Like, what can we do to give them food that we were delivering on campus, but not really on campus anymore? And then also that a lot of people avoid talking about the significant stressors, but we thought that it was really important to name that there was a pandemic going on for these families and George Floyd's murder. Like we wanted to make sure that we mentioned these things to our families so they had a room to process it, whatever feelings that they had of it. So just making sure that we are addressing what are we really dealing with here. Next slide, please. So I think that another thing to think a little bit about is that a lot of us work in pretty high volume, stressful conditions, and that just got worse during COVID. I think a lot of our clinics probably had less people during that time, but we all have been in places where the volume is too high, the visits are really short, we can't provide adequate follow-up, and then we don't feel like we're meeting the needs of the patients that we serve. And so some thoughts that can come into our head are like, I only have a little bit of time, so I just need to focus on these high priority items. So I will only ask about these things that I feel are important. And the other things I just can't focus on this time around. And another thing that people start to think a little bit, it doesn't really make a difference if I answer this email, phone call, or call in sick. It's just a job and everyone's overwhelmed anyway. We're not really making a difference. And we could also feel thoughts of like hopelessness. I just feel really bad for this patient, but what else can I do? I'm just hampered by this system that really isn't gonna work. I know that in my clinic, when I do work with youth and even adults that are in an urban population, I always have to ask them, what medicines are you taking? Are you taking them every day? What are your major concerns for today? Because if you start to think that you know the high priority, then you're gonna miss what the patients really feel are their high priorities. So we can move on to the next slide. So it's really important that we still do spend the time to do it. And if we don't, that we offer opportunities so that people can still reach us when the appointment was too short and things like that. And it can also lead to just a feeling of detachment from the work. You know, as you go through, for people that are in psychiatry training or just in general in medical training, we just start to lose our passion for the work with education, you know, just learning the books and trying to figure out, you know, what we need to do to pass tests. And then we get to like clinical residency and, you know, we're just looking at how the systems work and we just never feel like we have enough time for our patients. And I think that's kind of sad, because why do we initially get into the work? It was a passion that we had for the work that we did. And if you start to get detached from the work, you've kind of really lost that passion. And then what you can do is start to minimize the patient's concerns, or that they're not that big of a deal. And this is the only thing that I can focus on. Everything else isn't really that big of a deal. So you don't really provide the right referrals or interventions that the patient may need. Next slide, please. So sometimes some ways to kind of deal with this, and especially with systems of care, is to make sure that you have room to openly talk through these types of things, and that it's probably more than likely in systems of care like this that other staff members are really feeling the same way. And then you try and come up with creative ways to manage a system that isn't working. I know for myself, I work with different clinics that, you know, I have to make sure that I leave my patients some availability to call me, and I can call them, and it's not a full appointment, but they at least know that I can follow up with them pretty regularly. Also discussing no-show rates and how to improve that. Some people would think a little bit about if our clinic is overwhelmed, we can't provide the proper follow-up, do we shut down referrals for a while so we can serve the people that are with us better? And then we can add more resources in through time. Next slide, please. So who is more at risk and who is the most protected? So, you know, in my program, we have a lot of milieu specialists and people that are working directly with the kids that we work with. And the people that are more at risk are the ones that are with people every day, all the time. And mainly because they spend more time, they have less training, and they don't really get to learn how to navigate the thoughts, feelings, and actions described in the cases above. They just kind of come every day and do their job, even though it's really tolling on them. Social workers, psychiatrists, psychologists are probably more protected because they receive more formal training and things like this, and education, and are supervised. You know, we try and make sure that we supervise our trainees, and we check in on each other pretty regularly. People that have quality relationships outside of work, or that have really good self-care regimens outside of work, are also protected. You know, I think that during this time, I really feel pretty lucky, although it's been stressful to work in a house with another healthcare provider and have 3 children. I actually think it's protective in some ways also too, because all those relationships are quality and they help me kind of reset myself. Next slide, please. So, you know, at the end of this article, they have a really good, I'm going to reference the article at the end of this too, but it's just a really good quote that I think is super important. We all talk about interpersonal professionalism and things like that, but I really think that a lot of the stuff that I said gets tied up into this, and that really the balance between success and failure is all the more delicate when hospital treatment is conducted by a multiple of those staff members with differing perspectives. That means a truly collaborative approach where everybody is valued given their input. Next slide, please. So, you know, I was thinking about this presentation, you know, my wife brought up this term toxic positivity and sent me some articles about it too. And I just thought it was it resonated with me pretty well, that, you know, I think a lot of us just just continue to push on through times like this, and it can have some lasting effects on us. It really is okay to not be okay. A lot of families and friends try to get us to feel better by thinking of quick solutions for a lot more complicated problems. I can't tell you the amount of times adults have come into my clinic and just feel like all these people that try to support me want me to turn on a light switch and feel better. So things like, just go get some ice cream, you'll feel better. You know, just get up and go get some exercise. Just do some mindfulness or yoga. That works for me. Next slide, please. So how can this be harmful? So a lot of people with serious mental illness or just mental illness in general, burnout or significant psychosocial stressors, feel angry at their loved ones because they may not know why, but a lot of the time it's because they don't feel validated. They don't really feel heard about how hard things are for people right now. And they're always kind of forced to sweep them under the rug. So people start to avoid expressing themselves or even looking into treatment because they feel kind of weak because they can't get better on their own, and they start to feel more isolated. You know, a lot of the times I use the analogy that people with mental illness, you know, that if you broke a leg, you would go get help and get treated and feel healed. But why is it with things like severe depression or severe anxiety, we feel like we're weak because we can't get through it? And it's just, these are serious medical conditions. And a lot of time people feel better when they know that it's not them, this condition is really taking over them, and that that people can help them work through this. Next slide, please. So, you know, when I first started back as faculty at Tulane, I found this just great article, and it kind of highlighted in some of the cases I talked before, just about countertransference and transference, and about how managing really difficult situations and how to like work through the own feelings that you have, because we all bring our stuff into our relationships with our patients, and our patients bring their stuff into their relationships with us, and how to manage that. So the first bullet is an article about that, and then the second bullet is an article about toxic positivity and some of the things that I brought up there. I think that is it for me, so we can move on.
Thank you very much, Dr. Khunkhun. We're going to move on to the next speaker. It's Dr. Figley. We can have his slides.
Well, while we're waiting for the slides, I'm glad to be here, and hopefully this will be useful to everyone. I think everyone who is listening has some stake, some experience in COVID, especially in New Orleans, and I think that the presentations so far have been really stellar, and hopefully mine will be useful.
I have no doubt it will, and you're right, the presentations have been very informative. We should be coming up with the slide hopefully very soon. Technical difficulty, I'm being notified, so.
Well, if I could just jump in.
Absolutely.
Okay. All right, I haven't been introduced yet. I guess I have, really. But it's interesting because both of the presenters really talk about what they've experienced, what's actually happening right now, and why we have this program. They're talking about the specifics of their field and of the patients and clients that they work with. And for us, in social work in particular, we really don't have clients who are, you know, on death's bed, in effect. So what I decided to call this presentation is Trauma and the Human Costs of Humane Caring. And that's what I've heard from both of my colleagues in presenting here, and what we want to get across definitely along the way this evening and beyond. Next slide, please. So the purpose really is a lecture, if you want to call that. It's a conversation about caring for yourself, because this has been mentioned throughout the evening, but I really want to emphasize this in my time. This is caring for yourself while treating the traumatized and supporting our colleagues. And we can't leave out our colleagues and devoting ourselves and supporting them. And at the same time, we're working with traumatized people. So that's really an important element, but we have to be focusing on ourselves and how we're doing as we deliver these services. Next slide. So first of all, I'm the trauma person apparently, and I just want to emphasize a couple of things that are pretty obvious, I think, to most people. First of all, trauma is a spectrum. It isn't just one trauma fits all. It's a wide variety of traumatic events and traumatic stress reactions, all the way from a minor automobile accident that no one was hurt, all the way to an automobile accident you almost were killed in. It is a spectrum. It's also both a cause and an impact, an effect simultaneously. And of course, trauma is found everywhere, and we now know it's been experienced throughout history. They may not have called it that at the time, but it definitely was. So thus, it's a highly likely that our patients will be traumatized. Next slide. So in the presentation, I have four major questions that I'm going to address. The first is, what are the requirements for caring for our patients during a pandemic? What's required of us? What do they need, in essence? The second question, the major question I'm hoping to answer and address is, what are the costs of caring during these times? If we're focusing on our own self-care, then where are the things that we're vulnerable? And numbers of incidences were pointed out earlier on in the presentations. The third question is, how can I be compassionate and remain resilient? If I'm too close to folks who are having these traumatic experiences, will it drag me down? That kind of idea. And then the fourth one is, how can I increase my self-care regulation? How can I regulate my self-care so that I can be at my best at work and at home? Next slide. So with regard to the first question, what are the requirements for caring for our patients during the pandemic? Now, I'm trying to be a little clever and funny here, but in some ways I am serious about this. To wear a mask, obviously we all have to wear a mask, and especially medical personnel. But what I'm suggesting is to draw a smile. I mean, it may need to have a white mask, but one way or the other to show your emotions, to show your humanity, and for you to feel good about that as well. When I'm going to the market and various other places, I'm concerned that no one can really, they can see my eyes, but they can't link it to my face and to whether I'm smiling or not. So at the same time, we need as providers to receive expressions of appreciation with the same kindness that it was delivered. And even though some people don't really thank us in an appropriate way, and maybe in an accidental way, it certainly is important and necessary, and I'm hoping that it will continue. But it's very hard to be nice all the time, as was noted by several of the presenters. And it's particularly hard this time, in this period of time, as we're facing more months of this and the uncertainties. Next slide. The second question is, what are the costs of caring during these times? If we're concerned about ourselves, if we're concerned about providers, then we need to really think about compassion fatigue, the fatigue we get from the compassion that we deliver. But we also need to think about resilience. How can we spring back? How can we figure out strategies and ways that were discussed already tonight? Strategies and ways in order to maintain our resilience. Well, the model that I developed a few years ago with colleagues identifies the risk and protective factors resulting from variations in compassion fatigue and resilience. So let's see that model now. Next slide. So what we have here is a roadmap. We have a roadmap to one way or the other. We have a roadmap. We start on the left side because we as practitioners, we as service providers are responsible for an empathic response, that middle square there. So if we have the empathic ability, we can provide the empathic response, and we are exposed to those that are suffering. So we're able to adjust the empathic response to what they need. And then of course we're concerned. That's the motivation, to stick with it, to look them in the eyes, to be passionate and compassionate in the process of delivering this and asking them questions and how they're doing. But this, the first line of boxes here are really those that are protective to us, those that will make sure that we can become resilient. The first, of course, is self-care. We're always talking about self-care. We talked about it a little bit tonight, but we should be talking about it more, because that's really the primary source for us in terms of keeping our sanity, keeping our morale up. Self-care, everyone knows, is taking care of yourself, but there's always a self-care plan. You can say, yes, I have a beer from time to time, or oh, I go running from time to time, etc. But what is the systematic way in which you are accounting for the various stressors in your life and be able to manage that with specific skills? And self-care is certainly one of them, and one that is required in terms of on a continuous basis. The one down from that is detachment. From time to time, when we're working and when we're focusing on the client and what's going on there, we may become overwhelmed. And we may need to detach emotionally, physically even, from what is happening in order to protect ourselves, in order to enable us to be able to spring back. But each of these, the empathic response feeds the stress, the secondary traumatic stress, not the primary stress. The primary stress is when we are in harm's way and we are injured in that regard, emotionally or physically. But secondary trauma is where we help people who are in harm's way, not us, but other people who are in harm's way. So the detachment is helping us and enabling us to be able to adapt as we're working with clients and patients or colleagues. The sense of satisfaction is another useful, helpful, buoyant factor. It increases, obviously, our sense of satisfaction, but it also, we have this sense that we receive direct and positive reactions to our dispensing with health, with care. So there is this sense of satisfaction that we get when we're delivering the services, as in the empathic response. The second, the one right down from that, below that, is social support, and everyone recognizes the importance of social support, and probably everyone has social support. But do we have enough? If you're working with traumatized people on a regular basis, whether you're a psychotherapist or you're a physician, you are going to need more social support. You're going to need more sense of satisfaction. You're going to need to detach more, and you need more self-care, because it's extraordinarily challenging in working with traumatized people. We now know that. I have known this for a while. But the world now recognizes how difficult it is, both with regard to the diagnosis, but also the treatment. So all of these four factors go right into secondary traumatic stress. It elevates our ability to deal with things. It lowers our stress and increases our resilience. But the negative factors are the things that drag us down. One thing in terms of a negative factor is the empathic response, because we know for sure that the empathic response is extraordinarily important. In psychology, we've studied and learned this long time ago. But empathic response is extraordinarily important, but it also is when you're looking in someone's eyes and you're saying, you're deeply hurt by this, and they start crying. Tears come flowing down their face. You know that you've hit a nerve, and you know that you're right on target with regard to their emotionality. And so it's really a skilled practitioner who is able to immediately connect with that and to do something about it. So empathic response is extraordinarily important, but it doesn't mean that we're out of harm's way. Indeed, it's a conduit to that kind of problem. It is, as it were, a direct increase in secondary traumatic stress. But there are three factors that drag us down. One is prolonged exposure to suffering. Some people, as we know, are junkies, if you will, with regard to trauma and go on disasters, etc., and can't get enough. But most people are can just handle so much of this suffering. So the prolonged suffering, even though it may go beyond the pale, beyond what you expected or you're able to handle, it's extraordinarily challenging and difficult. But the problem, though, with some people as practitioners is that they don't know when to stop. They don't know when it's too much. Similarly, there are traumatic memories that we carry around with us that are unresolved, and our clients bring it out. They remind us of the things that are trapped inside of us, and we hadn't really thought about until we have a particular client who has these kinds of challenges and difficulties. And and as a result of that, sometimes we're able to clear up and resolve our own kinds of traumatic stress and memories, but frequently we don't. So we have to work on that, just like we have to work at managing prolonged exposure. And the other thing that I want to mention is other life demands. Life goes on, no matter how you're feeling. And those kinds of things come into our life whether we like it or not. I have a beautiful BMW out there outside that is not working, and I have to make sure that I get that fixed. It's the same way with those of us who ignore ourselves and end up in the same kind of place. So irrespective of whether it's a demand now, if it's a life demand, it will definitely intervene. And then finally, as a result of the processing and secondary traumatic stress, we hopefully will have very little, if any, compassion fatigue. And if we do, we'll have a lot of resilience to be able to spring back. Hopefully that's helpful. Next slide. Okay, so the third question is, how can I be compassionate and remain resilient when we have all of these challenges, all of these difficulties? Well, I'm suggesting that we have 5 capabilities that, with regard to work stress resilience, because that's really what we're talking about now. We're focusing on the context of work. So we see here that we have work stress resilience is absorbed by these 5 capabilities. And what I'm suggesting is, for those of us on the panel, as well as others who are working with traumatized people, especially those that are seeking help, we have to have these capabilities in all 5 areas. So if you are dragging a little bit, if you're not as looking forward to work as you normally do, be checking out these 5 and to see if that might be an issue. Because, let's see, I think there's a slide on each one. Next slide, please. Next slide. Yeah. So physically capable, in terms of reducing the distress, is measured by the level of energy due to sleep and health. Next slide. To be psychologically capable, you measure, among other things, your level of enthusiasm, your intellectual capacity or capability, your morale, your spiritual support. All of those things go into your being psychologically sound and able to differentiate what clients are saying to you. Next slide. Interpersonally capable, being able to interact with other people in a professional way, if not a civil and kind way. It is measured by the level of social support that you receive and that you give. And also the cohesion of your work group. Do you guys naturally hang out together, or you can't wait to get away from each other? Next slide. Excuse me. Technically capable, and it really depends on your particular role, what equipment you might be using, but irrespective of that, there is always a technicalities associated with your job. And these are measured by standards of productivity, client satisfaction, and competency scales. Next slide. And then, of course, there's self-care and self-regulation, which obviously is very, very important, and we've talked about it a bit already. But it's you're capable here in terms of self-regulation, and it's measured by existence of evidence-based self-care plan and following that self-care plan. Next slide. So how is your self-care regulation and working with the suffering people? How are you doing in that regard? Next slide. So this is the book that I published a few years ago on physicians' stress, and the term that the title we use is First Do No Self-Harm. And this was written by 3 of my colleagues, and it was contributed by almost all physicians. Next slide. So what we need to do, and what all of us need to do, is to be mindful of the impact of your help on the traumatized and the impact of those traumatized people on you, and to notice that, and to be mindful and to be sensitive to what other people are saying to you. Next. And use self-monitoring all the time, and most people do. Use self-compassion. Be compassionate for yourself, not just to your clients. Self-help is extraordinarily important, as is self-care, but sharing the responsibility of your work is incredibly important. Next slide. And that's my contact. Thank you.
Thank you very much, Dr. Figley. We're now going to go to some questions from for our panel, and we're going to start with a question for Dr. Hinshaw-Fuselier. And Dr. Hinshaw-Fuselier, in addition to mental health consultation to pediatric providers, what other kinds of services can be helpful for families and children who are feeling overwhelmed or trying to manage challenging behavior?
Sure, yeah, there's a whole range from promotion and prevention to specialized intervention. And things like home visiting programs, for example, for young children that are there for long-term support. So things like nurse-family partnership and parents as teachers. Those kind of supports can be very helpful and can help get families linked with other resources. And then specialized resources. So you can use organizations like the American Academy of Child and Adolescent Psychiatry, the National Association of Social Workers, the APA, some organizations like that to give guidance on what kinds of treatments are recommended, but you want to look for evidence-informed or evidence-based treatments. And Tulane has a number of specialty clinics, so you can check those out on the Psychiatry website.
Thank you very much. Our next question is for Dr. Figley. And the question is, what worries you most about folks living in isolation?
People living in isolation. Normally I wouldn't be at all concerned, but obviously because of this pandemic and the direction indeed of huddling in your house can be extraordinarily difficult for people who have difficulty in isolation. And those who are practitioners can talk about the disorders. But it is a very bad idea to huddle by yourself. And one of the things that I've done actually is to reach out to colleagues and friends of mine that don't have family and that are older. I know I'm older. So it's extremely important to look out for everyone and to make sure that someone has their eyes on them, especially for isolation. Thank you.
Thank you very much. So we have a question for Dr. Khunkhun. And this question is, how have you coped with COVID and what is happening in our country? That's a complex question.
Yeah, you know, I think COVID has been rough. Like I said, I have a wife that's a palliative care physician and 3 young boys that are 9, 5, and 2. And they we were talking a little while when we first started about them gophering up on all my conferences and screens during the pandemic. So it's been challenging in that way, but I think that it's also been pretty protective. I mean, being in isolation by yourself or being with others, I think has been pretty protective. You know, I'm just lucky to have, like, you know, people can't touch each other, but to have like your children be able to hug and touch you, I think has been very protective. And, as far as the world goes and how things are, I think that for me, I've been so used to living in my silo and doing the work that I do for the population that I treat, which I do think can make a difference. But I've just really felt an urge to get out of it and really kind of fight for what I think is right in the best ways that I can. And I really have a big heart to get out of it all and really do what's good to get this country going again. And I really challenge all of us to do the same.
Thank you. We're going to go back to Dr. Hinshaw-Fuselier with a second question. And this one is, how do cumulative adverse experiences impact children's health?
So a lot of the research that we have from the last couple of decades on adverse experiences has been with adults, but more recently there's been some research looking at kids under 5 and looking at children under 5 who have had 3 or more of these kind of adverse or stressful experiences that we've been talking about, traumatic experiences. Those kids are 2.5 times as likely to have physical health problems. They are 2.5 times as likely to have developmental delays, and they are 8 times as likely to have mental health problems by the age of 5. So it's really imperative that we begin to recognize and identify these things and get in and help and use it as an opportunity to really impact the trajectory of kids' health, because it's a lifelong affair, and it's setting them up for problems as adults as well.
Thank you. Thank you very much. We have another question for Dr. Figley. This is a somewhat personal question, Dr. Figley. Someone in the audience says, what's it been like to be away from your grandchildren?
They were probably among the thousands that I've complained to. Yeah, we were able to get together with 2 beach houses, our beach house, it's not too far away, and a beach house that we rented, and the kids stayed in. And it's the first time that we've seen these children since February. And I have to admit, I screwed up. I rushed in and hugged all of them. And yes, that's the wrong thing to do. Yes, we're confident that everything is going to work out well, but it is extraordinarily difficult. And those who know me know that I'm very family-centered, and it's been very, very hard. Thank you for asking, I think.
No, thank you for that reply and honest sort of response. We're going to go to back to Dr. Khunkhun with a question around physicians, and what is the best advice you have for physicians and healthcare providers that are dealing with burnout, anxiety, or depression?
I think that the first step is to be able to understand why you got into the field and to be aware of why you did it and what is taking away from the passion why you first got in it. And then also recognizing signs and symptoms of it too, things like sleep, appetite, interest, concentration, things that are keeping you up at night. And I would advise, once you feel that you cannot function anymore, or even hopefully even before that, you seek out help. I mean, obviously self-care, things like yoga, meditation, exercise can be helpful, but when you've tried all those coping mechanisms that are not working, that going to get treatment to me can be very helpful and very protective. And the ones that are severe are the ones that feel the most alone. And those are the ones that we worry about the most. So I think that's the best advice I can get. I mean, my dad used to say this a lot, that he loved his work. He never considered it work. And I have to say the same thing. I love my work. I don't call it work. And I think that so much of us have lost the passion for why we do what we do.
Yes.
I realized I was muted. Thank you very much. We're actually right on time at the end of the hour. There's a whole series of questions that have come in. We're going to get answers to all those questions. They will be answered in the chat room, and Cynthia Hayes will be sending out an answer to all of those via email. So thank you to the panel for excellent talks. I think everybody has found this very informative, great presentations. I want to thank the events team. I want to thank Cynthia Hayes, who's director of our medical school alumni relations and development, for helping put this together. Thanks again to everyone, and have a great evening.